Welcome everyone to the From the Experts All Things Celiac webinar series. Today's webinar is Building a Strong Foundation, Celiac Disease and Bone Health. It is hosted by the National Celiac Association and the Harvard Medical School Celiac Education and Research Program. The Harvard Medical School Celiac Education and Research Program was founded in 2013 by celiac experts from 3 Boston hospitals: Dr. Alan Leichner of Boston Children's Hospital, Dr. Kieran Kelly of Beth Israel Deaconess Medical Center, and Dr. Alessio Fasano of Massachusetts General Brigham Health. The highly collaborative Harvard Medical School Celiac Education and Research Program has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. I am Chris Rich, CEO and Executive Director of the National Celiac Association. The National Celiac Association provides educational resources to our celiac community, such as this Ask the Expert webinar series, our Raising Our Celiac Kids program for kids and their families, and our Supporting Celiac Seniors initiative. We have over 70 support networks across the country, and our Feeding Gluten-Free program is delivering gluten-free food to food pantries in over 3,000 communities across the United States. You can find more information about these and our other programs on our website at nationalceliac.org. For today's event, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. Closed caption is available by clicking on the CC button. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat box during the webinar. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org. That is digitalmedia@partners.org. Or you can reach us by phone at 857-282-6470. This session is also being recorded and will be available for viewing on the National Celiac Association's website. That address again is nationalceliac.org. Our moderator today is Dr. Dan Leffler. Dr. Leffler is a practicing gastroenterologist caring for patients with gluten-related disorders, including celiac disease and other gastrointestinal disorders. He is a founding member of the Celiac Center at Beth Israel Deaconess Medical Center and Associate Professor of Medicine at Harvard Medical School. He has received multiple grants from the National Institutes of Health, numerous foundations, and industry members supporting his research to advance digital health. He has authored or co-authored more than 150 articles in peer-reviewed literature and co-authored a patient-focused book with Melinda Dennis titled Real Life with Celiac Disease: Troubleshooting and Thriving Gluten-Free. He joined Takeda Pharmaceuticals in 2016, where he's a senior medical director and global clinical leader for celiac disease in the gastrointestinal therapeutic area. Welcome, Dr. Leffler.
Thanks so much, Chris. Pleasure to be here and really excited to share this webinar with you all. As you know, building a strong foundation, celiac disease and bone health. Bone health is something that is important to all of us, whether you're younger or older, male or female. Having good bones, good bone health is critical for a long and healthy life. And so I am really excited about today's topic. I am sure we're all going to learn a lot. Just as a reminder for those of you who may have joined in the last few seconds, and I see those numbers are still increasing, which is wonderful to see. We love questions. Please put them in the Q&A box on the bottom of the screen. And if you are looking for CEUs, continuing education units, please fill out the survey at the end of the webinar to be eligible for those. And so we are going to be having 3 talks, and then we'll have Q&A all together at the end. So put the questions in whenever they occur to you. We will sort them, but all panelists will be answering them together at the very end. So without further ado, I would like to introduce our first speaker, Dr. Deborah Mitchell. She is a pediatric endocrinologist at Mass General Hospital for Children, where she directs the Pediatric Endocrinology Fellowship Program and co-directs the Pediatric Bone and Mineral Metabolism Clinic. Her clinical and research interests center on skeletal metabolism in children, particularly the impact of chronic disease on bone accrual during the critical childhood years. Clinically, Dr. Mitchell specializes in patients with low mineral density of various causes, including celiac disease. So thank you very much, Dr. Mitchell, for joining us, and we look forward to hearing from you.
Great. Thank you so much for the opportunity to speak, and let me share my slides. All right. Any trouble seeing them, let me know. So thanks so much for the opportunity to talk about the role of celiac disease in bone health during the pediatric and adolescent years. And these are my disclosures. So we're going to be talking today about linear growth deficits in children with celiac disease, about bone density deficits in children with celiac disease, and then how to optimize bone health in children with celiac disease with the goal of optimizing bone health throughout the lifespan. So I'm going to start with a case talking about linear growth. So this is a young lady who was referred to me right about the age of 12, almost 13, with a concern of poor growth. So if you're looking at your growth chart, what you can appreciate is around age 3, she was at the 50th percentile for height. Typically, children around the age of 3 or 4 will kind of settle into where they are in their growth chart, and then their growth will continue along that path. But what you can notice is that was not the case for her. So at age 4, she was down at the 25th percentile. By age 5, close to the 5th percentile. And by age 8, she was down far below the 5th percentile. She had a pubertal growth spurt, but really kind of never got back up to where she was. The other atypical thing about her growth chart is that children tend to be roughly the same heights as their parents. So a child who's at the 5th percentile with petite parents, we might not think too strongly about, but a child with parents who are of average height, like this child, is fairly atypical for her to show this growth pattern. So when I examined her, her exam was really totally unremarkable. And on history, she really had no symptoms concerning for anything, including a really detailed gastrointestinal series of questions. That being said, her growth pattern was so atypical that I did do some screening tests. And I'm sure you're not surprised to hear, given the topic of this talk, that her TTG-IgA was elevated. She then went on to endoscopy and was diagnosed with celiac disease. So on the one hand, great, we made a diagnosis. Now she can get treatment, but that diagnosis kind of came at a cost where she's now close to the tail end of her growth, and her adult height was never going to be kind of where it would have been had the celiac disease been diagnosed earlier. Kind of thinking more broadly, now that we have this case in mind, how is growth regulated, and then how does celiac disease affect that? So linear growth, people tend to think about it as being bone related, but really the key organ in growth is that growth plate. So the chondrocytes, which are the cartilage forming cells within the growth plate, they proliferate, so they divide and they hypertrophy, they get bigger, and that drives the growing, the lengthening of the bones. So this requires energy intake, so it requires good nutrition. It requires multiple hormones, which is why as endocrinologists we get involved in concerns about growth. So it requires growth hormone, thyroid hormone, the sex hormones, estrogen and testosterone. And importantly, those inflammatory cytokines, which we can see in celiac disease being elevated, they tend to inhibit chondrocyte proliferation. So that can be one of the real main drivers of poor growth in celiac disease. So what do we know more generally about growth in celiac disease? So in one systematic review of children who were asymptomatic, so like the patient that I saw, who were evaluated by an endocrinologist for short stature or poor growth, somewhere between 2 to 8% of those were diagnosed with celiac disease. And that is certainly consistent with what I have seen in my practice. And then among children who an endocrine disorder had already been excluded, so their growth hormone was fine, their thyroid was fine, they were proceeding through puberty normally, somewhere between 19 and 59% of those children had celiac disease. So as endocrinologists, we are now trained. So our consensus guidelines say if we are evaluating a patient where any concerns about growth exist, we screen for celiac disease as kind of one of the first line things that we do. This is a study highlighting the importance of early diagnosis. So this is a study of 177 children in Finland with celiac disease. And as you might know, in Scandinavia, they have incredible detailed records. So they were able to compare these 177 children with celiac disease and compare growth parameters to 50,000 other children in Finland who were matched for age and sex but didn't have celiac disease. And what you can appreciate is that at the time of diagnosis, here on the right, with girls shown in the orange and boys shown in the blue, the girls and boys were both had a lower height than the unaffected children in Finland. But you can appreciate that that decrease in height started earlier. So even around 5 years, it looks like they trended a little bit lower, although certainly those confidence interval bars cross 0. But by 2 years and 1 year before the diagnosis of celiac disease, the growth had already been affected. So really to highlight for us that a vigilant attention to growth charts can really promote the early diagnosis of celiac disease. So again, why do we see growth being affected in celiac disease? It could be general malnutrition. So in children with real severe celiac disease who have that kind of classic, wasted malnutrition, diarrhea type of picture, there can be a frank calorie deficit, but that's not often what we see in children with celiac disease. There may be selective malnutrition, so micronutrient deficiencies, for example, a zinc deficiency, that chronic inflammation, and some children with celiac disease can also have delayed puberty, and that can slow the progression of that growth spurt during puberty. Does growth get better with institution of a gluten-free diet? We think it does. So most children will display robust, what we call catch-up growth, so get back to where they would have been on the growth curves, as long as they have enough time to do that after the institution of a gluten-free diet. But like in our patient, the late diagnosis can lead to a permanent height deficit. So one study done at Columbia University in New York looked at 585 adults who had celiac disease who were diagnosed as adults, so after the age of 18. And on average, men were 8 centimeters or 3.1 inches shorter than the general population. So the average man in the United States is about 5'10". The average man with celiac disease was about 5'7". Interestingly, the women didn't seem to have as significant a height deficit in that study. A different study in Israel looked at 290 adults with celiac disease. Overall, there was no general difference in height between those individuals and that of the general population. Although, again, in the men, the older patients were, the more likely they were at diagnosis, the more likely they were to be on the shorter side, again, pointing to the importance of early diagnosis. So in terms of recommendations about growth in celiac disease, we know that growth is likely optimized by a younger age at diagnosis, likely optimized by degree of adherence to the gluten-free diet. And one question that we really need to sort out is, does perfect adherence to a gluten-free diet totally normalize growth, or are there still subtle deficiencies in growth that maybe need to be further addressed? And then it really also highlights the importance of advocacy, so training physicians and other medical providers to identify and evaluate children with growth failure. And I think this has been a major success. So when I first started out in practice in pediatric endocrinology 10 or 15 years ago, I diagnosed celiac disease all the time. And as I've been discussing in our pre-seminars, I haven't diagnosed celiac disease in a few years, and that's because the primary care community really now has been so well educated by advocacy, by this organization as well as others, and most children who are now coming to me with growth failure have already been screened by their PCPs for celiac disease. So I think that's a real success story. So what do we know about bone health in celiac disease? So very severe untreated celiac disease can present with very severe bone disease. So osteomalacia, which is a poor mineralization of the bone that leads to softness of the bone and easy fractures, as well as rickets, which is that classic bowing of the bones that we see in young children. And this is secondary to really profound malabsorption of calcium. And unfortunately, in low and middle income countries, this really remains a common presentation of celiac disease. So this was a case report in the literature from 2014 of a 13-year-old Yemeni girl who lived in a very rural, remote village with no access to medical care. When she finally appeared for medical care in a larger city at age 13, she had severely bowed legs to the point where she was unable to walk. She was diagnosed with celiac disease, instituted treatment with a gluten-free diet as well as vitamin and calcium supplementation, and amazingly 4 months later she was able to walk. This again is a more severe presentation of bone disease than we typically see, but this is why we focus on bone health in the pediatric period, and it has to do with the natural history of bone accrual during childhood. So much like growth, most of our bone mineral that has to last us for our whole lives is built up during the key childhood and adolescent years. And in fact, during that growth spurt, in the 4 years kind of around the peripubertal growth spurt, about half of all of the total body bone mineral that we are going to have for the rest of our lives, that's when that's acquired. And by age 18, we have roughly 95% of our adult bone mass. And then that remains pretty static over the next few decades. And then with aging, fairly acutely at the menopausal transition in women, and then more gradually in men, there's the initiation of bone loss. And with that bone loss comes an increasing risk of fracture. So why we care as pediatricians is that anything that's going to affect that bone accrual, that bone acquisition and development of bone architecture during childhood and adolescence is going to interfere with optimal acquisition of peak bone mass. And then when we start losing bone as older adults, we're just that much more likely to get the fracture risk zone. So why do we care about fractures? And in pediatrics, sometimes people ask me like, why are you so worried about this? Because kids break their bones all the time. Between 30 and 50% of kids will break a bone before the age of 18. And most of those kids are going to heal up just fine and, within a few months be back to their regular levels of activity. And that is very, very different in adults. So in adults, we know that after a hip fracture, within that following year, there's roughly a 8 to 36% chance of death. And fewer than half of adults return to their baseline level of activity after a hip fracture. So they may not be able to live independently. They may need a walker or a wheelchair for mobility. Vertebral fractures, so fractures of the spine, often lead to a curvature of the spine, can lead to chronic pain. And if that curvature is severe, can actually lead to altered lung mechanics and difficulty breathing. It used to be thought that wrist fractures were kind of more benign, but in fact, more recent data suggests that 15% of people after suffering a wrist fracture then also go on to have a significant functional decline. So by focusing on optimal bone accrual during the pediatric time period, this is what we're really hoping to prevent. So how is childhood bone mineral density affected in celiac disease? So this is a complicated graph, but this is showing the results of 12 different studies. And in each of these studies, they compared the bone density in their cohort of children with celiac disease with an unaffected control cohort of children. And what you can see is the estimated differences of bone density between the kids with celiac and kids without celiac differed, but in general, they were all far below the unaffected kids. And then if you took the average, on average, the bone density was roughly 0.7 standard deviations lower in the children with celiac disease than in the children without. So if you look at a curve here, kind of a typical bone curve, a bell curve, the blue would show the distribution of bone density in a healthy cohort of children, and the children with celiac disease here in the red are shifted over to the left. So they don't have grossly abnormal bone densities, but the whole population tends to have just slightly lower bone density. So what does this mean for fracture risk? So I mentioned that kids with healthy kids fracture all the time. So it can sometimes be hard to distinguish, well, what's a normal fracture from a fracture that's caused by a chronic illness. So in population-wide studies, that can be where you can tease this out. So this is a study done out of an insurance database in Israel where they looked at about 2,300 kids with celiac disease and about 11,000 matched controls. And what you can see in the light gray here in the boys is that the kids without celiac disease, about 25% of the boys had a fracture before the age of 18 and roughly 20% of the girls. But if you look in the dark gray, the kids with celiac disease have a much higher risk. So a 50% increased risk of fracture in the boys and a 60% increased risk of fracture in the girls with celiac disease. And interestingly, this was true both before the diagnosis of celiac and after the diagnosis of celiac disease as well. So does instituting a gluten-free diet help? And the answer we think is yes. So there are numerous studies that have looked at bone mineral density in children after initiation of a gluten-free diet. And these data suggest that if you initiate that during that key peripubertal period of rapid bone acquisition, we can prevent or at least minimize the effects on bone health. So I'm showing here results from one study that compared kids with celiac disease who were either very strictly adherent to a gluten-free diet or who were kind of, less strict. And so what you can see is if you look at the bone mineral density Z-score, so how different are they from the general population at the hip, the kids who were strictly following the gluten-free diet had an average Z-score of 0, meaning they were no different than the general population, whereas the kids who were not strictly following the diet had a low hip bone mineral density Z-score. If we look at the bone mineral density for the whole body, the kids who were strictly following the diet actually, even they did not fully rescue their whole body bone mineral density, but they were certainly better off than the kids who weren't following the diet. So we really do recommend as strict adherence as possible to try to maximize bone health in this population. But more research, particularly using some more detailed imaging techniques that my colleague Dr. Bai is going to talk about in his talk, is really important to try to get at exactly how institution of a gluten-free diet affects the details of the microarchitectural bone acquisition in this population. So what can we do about it? And so the most important thing I recommend to my patients is physical activity. And the reason is that mechanical loading is the strongest stimulus for bone growth. So bone tissue is exquisitely sensitive to bone loading. And that has to do with these cells here, the osteocytes, which I have to say I think are the most beautiful cells in the human body. So these are cells that are embedded within the bone, and they have these projections called dendrites that extend out to the outside of the bone, and they're able to sense how much that bone is being strained and deformed with physical activity. And then the more strain that they're sensing, they signal to the osteoblasts, which are the bone building cells, to build up more bone. The effect of bone loading is durable. So we see people who, as adults, who were athletes when they were younger, and they still have excess bone compared to their non-athletic peers, even though they still aren't active anymore as adults. And we also know that the greatest response to mechanical loading is during that peripubertal period. So that's the time where we really, really want to focus on getting kids active. The activity does have to be vigorous, and it has to kind of involve loading. So swimming, fabulous activity, but doesn't really cause pressure on bones. Walking couldn't be better for your mental health, but we really need a little bit more banging on the bones. So things that involve running, jumping, or rapid side-to-side accelerations like tennis, soccer, field hockey. Those are the activities that we really recommend. So do we know whether children with celiac disease are going to respond to this mechanical loading signal in the same way that other children are? And there hasn't been a lot of detailed kind of look specifically at the celiac population. This is the one study I was able to find. So a study of 59 children with celiac disease, and their physical activity was assessed by a validated questionnaire by their recall. They wrote kind of down how much activity they participated in. The group is quite active. So on average, getting 55 minutes of vigorous physical activity every day, which is actually great and a lot more than I see in some of my patients. And those who are more active tended to have higher bone density. So that's really reassuring. There's no reason to think that kids with celiac disease are not going to respond to physical activity. The other really important thing from a non-pharmacologic standpoint is to make sure that calcium and vitamin D are optimized. So during peak growth, the calcium is depositing in our skeleton at a rate of about 250 milligrams every day. And the role of vitamin D is to enable the absorption of that calcium. So in the absence of vitamin D, of the calcium that we eat, roughly 10 to 15% is absorbed through our gut, and then the rest is kind of excreted. Vitamin D stimulates that by about threefold. So with adequate vitamin D, we absorb about 30% of our calcium. So for the 25D level, which is a marker of vitamin D sufficiency in the blood that is defined as adequate, is pretty controversial, and you'll find lots of experts arguing back and forth with each other over that. The Endocrine Society has come out and said that for patients where we're worried about their bone health, we're aiming for a little bit of a higher level. So 30 nanograms per milliliter is generally what I aim for, and what most pediatric bone experts will be aiming for in children where we're worried about their bones. So how do we optimize bone health in our patients with celiac disease? Number one is vigilant treatment of the celiac disease itself, nutritional counseling, and my colleague Katarina Mollo, who's speaking later in this session, is going to give you a lot of very specific information about what calcium and vitamin D targets that we're going to be aiming for and how to achieve those. And then promotion of physical activity, because again, that mechanical loading of the bone is what promotes bone formation. DEXA scans as a measure of bone density are not really recommended as standard of care in children who have celiac disease, and that's different than in adults that Dr. Bai will talk about, because we're really not going to be changing our guidance. We're really going to be trying to optimize everything we can, no matter what that bone density is. And thank you again for the opportunity to speak, and look forward later in this session to taking questions.
Thank you so much, Dr. Mitchell. That was a wonderful talk, and I see a number of questions have come in already. Please keep them coming. They're great, and we will get to as many of them as we can at the end of the session. So with that, it's my pleasure to introduce Dr. Julio Bai. Julio Bai has been a leader in celiac disease clinical care and research for many years now. I won't embarrass you by saying how many, but Dr. Bai is an adult gastroenterologist, Professor Emeritus of Medicine and Research at Universidad El Salvador in Buenos Aires, Brazil, and a consultant in the gastroenterology hospital in Buenos Aires, Argentina. Argentina, if I said Brazil, sorry. He was the director of the gastroenterology specialist program at the National University of Buenos Aires. His clinical and research interests were related to small bowel diseases, especially celiac disease. And one of the research lines specifically that he's contributed to over the years is skeletal metabolism in adults with celiac disease, particularly around the measurement of bone density and the impact of disease on fractures, structural aspects of bones, and the effect of the gluten-free diet on bone structure and health. So with that, thank you very much for joining us, Dr. Bai, and I'm looking forward to your talk.
Thank you, Dan. Thank you to all my friends in Boston who invited me for this exceptional meeting, webinar. And my talk is about my experience on adult celiac disease patients and bone health. We started exploring this topic many years ago. In terms of the historical perspective of wound health in celiac disease, there is more than 100 years of knowledge about disturbances in bones on celiac disease patients, osteoporosis, osteomalacia, rickets, bone osteoporotic fractures, and skeletal deformities. But the change was produced in the 1980s because there appeared new instruments, new tools for diagnosis of bone mineral density with precision. And that was in early 1980s. And there are a lot of seminal studies about bone mineral density in celiac disease patients, and most of them were done in Italy. We started very soon after that. Some very few general considerations. I will speak about bone mineral density measurement, pathogenesis of osteoporosis, clinical consequence such as the fracture risk, pathogenesis of fractures, and finally, therapeutic tips. Bone mineral density measurement and pathogenesis, the next point. You know that the bone is very active tissue, dynamic, and it's going from bone synthesis to bone resorption. And this is continue over the life of our life. And the potential negative effect on bone health is usually associated to the age of diagnosis. Early detection and treatment of celiac disease can prevent of diminished bone impairment. What about bone densitometry? There were early tools, instruments for measurement of bone densitometry. Most of them were based on isotopes, but the appearance of DEXA, that is dual X-ray absorptiometry, is a 2D observation of bone structure and bone density. Early studies showed that osteopenia and osteoporosis was very frequent in celiac disease patients, especially looking at osteoporosis. At that time, untreated celiac disease had of 30 to 40%, 45% of patients, untreated patients had osteoporosis. But treated patients also have osteoporosis, 20 to 30%. And also asymptomatic patients, 25% of them had also osteoporosis. And you know, this is for me very important. The prevalence of osteoporosis in celiac disease have been shown to be influenced by the level of alert on celiac disease. And remember that those studies that established prevalence of osteoporosis were early studies, where most patients were symptomatic at that time. And that was our results of analysis. But following that investigation, we produced a longitudinal study from the diagnosis of celiac disease to 1 year after the starting on a gluten-free diet. And what you can see on the left is that most patients increase bone mineral density after 1 year on a gluten-free diet. But what happened after that? We followed those patients for 5 years, 5 more years, and we saw that improvement in bone mineral density continue on the time. And I think that is very important because never finish the rebuilding of bones. Gluten-free diet for 1 year. This is the final message of this slide. For 1 year, increase the bone mineral density both at lumbar spine and total skeleton. Then the improvement still continue 5 years after diagnosis. What about factors involved in osteoporosis? As you have seen recently by Dr. Mitchell, malabsorption it was considered the first and most important cause of impaired bones. But we know that genetic predisposition, not only for celiac disease, but also for bone impairment in non-celiac patients, autoimmunity, local and systemic immunity, and perhaps microbiota could make strong participation or have a strong participation in this balance between bone formation and bone resorption. I only want to show you that this negative balance between synthesis and resorption of bone material is the cause of osteoporosis. But I want to go back to genetic predisposition. This is not related to celiac disease. This is just related to the predisposition to have bone impairment in general population. And there are a lot of potential genes involved or suggested to produce osteoporosis. But what I want to show you here is what happened with a variant of the allele IL-1B known as 511.2. And you can see there a group of patients that were diagnosed, and this is the bone mineral density. And you can see there those patients who were non-carriers of the variant. And in yellow and gray, you have those who are heterozygotes for the variant, and in light yellow, those who are homozygotes. That means that perhaps there are two hits in the natural history of bone impairment. First, the general genetic predisposition, and then is the advent of celiac disease. What about clinical consequences, factor risk? And you can see our first study that I think it was the first study of bone fracture, clinical aspect of bone deterioration. And you can see there it was a cross-sectional study, but you can see there patients at different ages. And you can see that celiac disease patients, they have a higher frequency or prevalence of fractures compared to non-celiac disease controls. And that there is 2 periods of time in the life of patient where the increased fracture risk is higher. One is around the 30 years, maybe sports have something to do with that. And late after 60 years, once again, you can see there this increments. there is an excess of fractures compared or celiac disease patients, the bottom line, compared with non-celiac disease control. Sorry, just a moment, please. Well, very soon after that paper, I realized that there were differences with other studies performed, for example, in London. They didn't find at that time that there was increased risk of fractures in celiac disease patients. I thought that similar to other experience that I had before, we were looking at different patients. And at that time, we performed a new study where we divide patients in classical celiac disease cases at diagnosis and subclinical celiac disease cases. And you see there that those with classical celiac disease, probably related to malabsorption, have a significant increment of risk of fractures. And what was the most frequent excess of fracture? Probably because we saw, we look at people below 60 years old, the excess of fracture was significantly related to symptomatic celiac disease. And the most frequent cause of fracture was the Coles fracture in ribs. But that was not the only study that was different to our result. And at that time, in 2008, we did the first meta-analysis about fractures in undiagnosed celiac disease. And we saw there that there was a 60% of increment in the risk, in the prevalence of the excess of fractures. And this was a biased and controversial study. Probably the most significant difference we had was with the Swedish population-based study. But some years later, we repeat in a multi-center study, we repeat once again the study about fractures. We saw there that males have fractures than female, more risk, and that after diagnosis, the risk of fractures normalized. And the other thing that we saw there was that we confirmed that classical celiac disease patients have more prevalence of fracture than subclinical. Gluten-free diet have more fractures, significantly more fractures than patients with non-celiac disease. Oh, sorry. Years after our study in Finland, there was a new meta-analysis that showed that there is also increased risk of fractures, also in retrospective studies and also in prospective studies. Well, what about factors associated with the risk fractures? Bone stress and osteoporosis are really important risk factors for fractures. But also it's important the impact of trauma. People doing sport or old people have more risk for fractures, especially because they may have a higher impact of trauma, but also increment of the risk of falling. But we put special attention on bone stress and osteoporosis. But the new aspect of celiac disease is a three-dimensional analysis of structure that was done by a special CT scan, that there is no high-resolution peripheral quantitative CT scan. Some people has to recognize as virtual biopsy. What you can see there at the bottom of the slide, that what is the structure of trabecular bones, and you can see on the right, on the left, normal trabecular structure, and on the right is very clear that you can see what happened in trabecular bones in osteoporosis. And here you can see what is a real analysis, the PQCT analysis of distal tibia in healthy control, and also what you can see there was this the structure of trabecular bone in untreated in a woman with celiac disease at the time of diagnosis. And we can see, we can separate cortical bone, but of cortical bone, or the fact that you cannot identify difference before and after diagnosis is produced in the cortical bone. But the trabecular bone is very characteristic, and it's important because the strength and risk and pressure is important quality that can be easily demonstrated in untreated patient and result in quick recovery after gluten-free diet.
And there's a two-minute note, Dr. Bai. 2 minutes. Thank you.
Thank you, Melissa. Melinda, sorry. This is just to show you that this was a group of young women with normal bone mineral density, but abnormal density in terms of cortical thickness, trabecular density, and trabecular numbers, both at ultradistal radial and distal tibia. What about therapeutics? Just small, simple slide. What we can see there is the thickness of trabecules increasing after 1 year and continue increasing after 3 years of diagnosis while patients were on a gluten-free diet. Finally, therapeutic tips for celiac disease patient, adult celiac follow-up strategy. Until now, the gluten-free diet has been shown the most effective treatment for osteopenia and osteoporosis. In treated patients with bone mineral deterioration, look for lower compliance with a gluten-free diet. Calcium and vitamin if deficient, or when there is a high serum PTH, thyroid hormone. Currently, there is no support for use of bisphosphonates as a standard procedure. Every newly diagnosed adult patient should have their bone mineral measured at the time of started diagnosis doing DEXA. There is no evidence supporting DEXA in those with DEXA clinical phenotype or repeated testing to patients with normal baseline bone mineral density, except they are not adherent to the gluten-free diet or they are going to menopause and andropause. Well, this take-home message. 1990s marked the beginning of new era of our knowledge. Bone mineral density was available to recognize the risk of this complication. Early detection of celiac disease before bone mineral density deterioration is ideal. Symptomatic patients are mostly affected. Subclinical cases also exceed bone damage. But the fractures risk is increasing between 60% to 100%. Males seem to have higher risk. Subclinical celiac disease fracture risk, and fracture risk seem to normalize after 1 year on a gluten-free diet. There is a multifactorial pathogenesis. The trabecular bones seems mostly affected, and gluten-free diet induced significant microstructural improvement. Thank you. Thank you very much.
Thank you so much, Dr. Bai. That was great. So for our final talk for today's session, happy to introduce, bouncing back to Boston from Buenos Aires, Katarina Mollo. Katarina is a clinical dietitian at the Center for Celiac Disease Research and Treatment at Mass General Hospital, where she sees both pediatric and adult patients, so a nice bridge for our final talk. She's also consultant dietitian for the National Celiac Association. Katarina's passion for celiac advocacy has led her to pursue a career as a registered dietitian with a specialty in celiac disease. She has a Bachelor of Science in Food and Nutrition and a Master's of Education in Nutrition Education. Katarina has also a lot of personal experience with celiac disease, as she herself was diagnosed with celiac disease as a young child and has a daughter with celiac disease. So knows very much firsthand what it's like navigating life on the gluten-free diet and a lot of the questions that are being asked. So thank you, Katarina. Pleasure to have you.
Oh, thank you so much, Dr. Leffler. And thank you so much for the opportunity to present today. I'm just going to share my screen with you. All right. Can everybody see the screen?
Looks good.
Okay, good, great. All right, so happy to be here this afternoon. So I'm going to be focusing on celiac disease nutrition and the gluten-free diet for bone health. All right, so let's get started. So I have no financial conflicts. And today I'll be covering the importance of managing celiac disease and the gluten-free diet. And I'll also talk about gluten-free diet challenges and may be a barrier to achieve nutrition, and then I'll talk about nutrition and supplementation for bone health. So the gluten-free diet is the most important aspect of treatment, and it's crucial for bone health if you have celiac disease, as you saw also in Dr. Bai's presentation. So not adhering to the gluten-free diet leads to damage, as you know, in the small intestine, which leads to villus atrophy, and that will prevent the body from being able to absorb nutrients properly, including calcium and vitamin D. And this will lead to low bone density. It can also lead to a host of other nutrient deficiencies as well. So the most common nutrient deficiencies associated with celiac disease are iron, B12, folate, zinc, copper, vitamin D, and calcium malabsorption. And studies have found that about 38 to 72% of patients that have osteopenia or osteoporosis at diagnosis, and up to 70% of seniors have osteopenia or osteoporosis at diagnosis. So a DEXA bone density scan is recommended upon diagnosis for adults. So the gluten-free diet is the only treatment currently available for celiac disease. And managing your celiac disease includes, the gluten-free diet, so avoiding wheat, barley, rye, and contaminated oats, and always reading labels carefully on anything that you're eating or drinking, and always asking lots of questions about food, when you're out and about away from home, and watching out for cross-contact with gluten when eating at home and away from home. And celiac disease management also includes addressing any nutrient deficiencies, as well as growth or weight concerns. And it's very important seeing your GI doctor and dietitian for regular follow-ups. And I do recommend seeing providers that specialize in celiac disease. So how often should you have a follow-up? So we recommend seeing your GI doctor 3 to 6 months after diagnosis, and then 12 months after diagnosis. And then we usually see them annually. And this also varies with each individual case, as some may have to see their doctor more often due to complications. So during a follow-up, we would check things like the celiac antibody levels and test for nutrient deficiencies. We'd also check thyroid levels yearly, check on weight and growth, especially in children. And we also look at diet adherence to the gluten-free diet, and also monitor for other complications or autoimmune conditions associated with celiac disease. And we also recommend a repeat endoscopy after 1 year on the gluten-free diet to check for healing for those over age 10. So it's really important to see a dietitian, especially dietitians that are skilled in celiac disease. We play an important role in the gluten-free diet management, and we can address important things like diet education, diet adherence, nutrition-related issues, both those associated with celiac disease as well as other nutrition-related issues, and also address things like quality of life and psychological burden of celiac disease, as well as, help with navigating school and college environments. So these are the most common nutrition labs that we check. So iron or ferritin, complete blood count, B12, folate, vitamin D, specifically 25-hydroxy, zinc, and copper. And we usually check these at diagnosis and then yearly. What about vitamin supplements? So I always recommend a multivitamin for people with celiac disease, and it should be age appropriate and labeled gluten-free. And I also recommend a vitamin D, so 1,000 IUs a day for children under 12, and for those over 12 years of age, I recommend 2,000 IU. And for those with vitamin D deficiency, they may need a prescription dose, and I'll talk more about vitamin D later in the presentation. You also may need other supplements to address specific deficiencies based on your labs. It's common that people need extra iron, folate, B12, and zinc. So lactose intolerance is common at diagnosis. And the reason for this is that the lactase enzyme that breaks down lactose is made in the intestinal lining. And when we have damage there, it can lead to the body's inability to produce this enzyme. And when lactose is not broken down, it will get fermented by bacteria in the large intestine, and it will lead to unpleasant symptoms such as pain, gas, bloating, diarrhea, or constipation. For many, this is temporary and may improve as the intestine heals on the gluten-free diet. Some people are able to produce the lactase enzyme again and tolerate lactose foods again after they healed. However, some stay lactose intolerant. Lactose intolerance is also common with aging. And the reason why I bring this up too is lactose intolerance may lead to decreased calcium intake, as people may not eat as many dairy products. I also want to note that low lactose diet is not the same as a completely dairy-free diet. People with lactose intolerance can still have some dairy. They usually can eat things like aged cheeses, and some even tolerate yogurts. All right, so there are some common challenges with the gluten-free diet, such as being low in fiber, and this may lead to constipation. And it's also higher in starch content, lower in protein. It also usually higher in fat, sugar, and high fructose corn syrup. So these ingredients are often added to increase the palatability of gluten-free products. It's also generally lower in certain vitamins and minerals, such as the B vitamins, iron, calcium, magnesium, and zinc. And to kind of compound this, gluten-free products are rarely fortified with iron, folic acid, or other B vitamins like some of the regular gluten-containing counterparts. So what can you do? Well, I always recommend people eat, a variety of foods and focus on whole foods. So there are tons of, naturally gluten-free whole foods like fruits, veggies, lean meats, dairy, fish, eggs, beans, seeds, and healthy gluten-free whole grains such as amaranth, buckwheat, quinoa, sorghum, and teff. And for those times you do choose processed foods, choose enriched or fortified gluten-free grains or foods. I also always recommend the gluten-free Mediterranean diet. It's a really good diet for overall nutrition, and it's actually also good for bone health. So what is the gluten-free Mediterranean diet? So it's kind of what I already talked a bit about. You focus on whole foods, and mainly you focus meals around veggies, fruits, beans, gluten-free whole grains, and nuts. And again, pick those healthier gluten-free whole grains, the amaranth, buckwheat, quinoa, sorghum, and teff. And you want to use fats such as olive oil or avocado oil instead of butter or other vegetable oils when you're cooking. So eat mostly fruits, vegetables, gluten-free whole grains, nuts, seeds, olive oil, legumes, fish, and seafood. And eat in moderation dairy, eggs, and poultry, and rarely eat red meat, sweets, sweetened beverages, added sugar, processed foods, and refined grains and oils. So the Mediterranean diet has shown that it is protective against osteoporosis, lowers risk of fractures, increases bone mineral density and vitamin D levels, and finally, phenolic compounds, which is a type of antioxidant in olive oil, may protect against fractures. So the Mediterranean diet will also be rich in all the nutrients you need to build healthy bones, such as calcium, vitamin D, magnesium, protein, phosphorus, potassium, and vitamin K. So calcium and vitamin D are the two most important nutrients for bone health. Calcium is a major building block that helps build and maintain bones, and vitamin D helps with calcium absorption. All right, so how much calcium should I get per day? So adults between the ages of 19 to 50 should get about 1,000 milligrams per day, and those aged 51 to 70 should get 1,000 for men and 1,200 for women. And those over 70 need to get 1,200. And as you can see here, kids between the ages of 9 and 18 have the highest requirement and need 1,300 milligrams a day because they're growing a lot. And let's look at some calcium-rich foods. I'm sure you recognize a lot of these. So dairy, obviously, milk, yogurt, cheese, lactose-free milk, or dairy-free milk or yogurt, such as soy, almond, cashew, coconut, pea protein milks. There's also calcium-fortified orange juice. Tofu and soybeans also have a good amount of calcium. And canned sardines are one of the foods that are highest in calcium. It actually contains over 500 milligrams per cup. And there are several leafy greens that are also very high in calcium. And surprisingly, some mineral waters have up to 330 milligrams per liter. So definitely check the label when selecting mineral water. So here are some veggies that are high in calcium. So you may notice I did not include spinach in this list. Although spinach does have a lot of calcium, it also has something called oxalates in it, at very, very high levels of oxalates. And oxalates interfere with calcium absorption. So the body cannot really utilize most of the calcium from spinach for this reason. I also want to note that another benefit with leafy greens is that they also are very rich in vitamin K, which also helps bones. Like a cup of kale, for instance, would provide your whole daily requirement for vitamin K. And also the type of flour you use can also make a big difference on calcium intake. As you can see here, almond flour and teff are pretty high in calcium, actually. And compare that to rice flour and cornstarch, which many gluten-free products are made of. And you see here, white rice flour is only 6 milligrams, and cornstarch at a low 2 milligrams only. So what does a 1,200 milligram calcium diet look like? What would I have to eat? So it's actually not that difficult to reach 1,200 milligrams a day. It would be like so if you can have dairy, it would be like having a cup of milk, 6-ounce yogurt, 1.5 ounce cheese, a cup of cooked collard greens, and a cup cooked broccoli. That would put you at the 1,200. And if you don't do dairy, then you could do like a cup of almond milk, soy yogurt, 1 cup of kale, a cup of broccoli, and 2 cups of mineral water, and that would put you over the 1200. And if you're somebody who drinks milk with each meal, whether it's a dairy-free version or the regular milk, it would be very easy to reach the daily recommended amount. So non-dairy alternatives, they usually always fortified with calcium. So they usually have about similar amount of calcium in there as regular milk. So what about calcium supplementation? So if possible, I always tell people, always recommend getting calcium from foods first. However, sometimes this is not always possible. Some people may need supplementation to reach that, 1,000 to 1,200 milligrams a day. So the most common supplements are calcium carbonate and calcium citrate. So calcium carbonate is generally more affordable, but it's not well absorbed, and it has to be taken with food, and it can also cause constipation. It also lowers stomach acid, which can interfere with the digestion of other foods. Calcium citrate, however, is preferable because it is better absorbed, does not lower stomach acid, it does not have to be taken with food. And here are some other tips. If you're taking calcium supplement, divide it into smaller doses, so it will be absorbed better. Divide into 500 milligrams or less, and take at least 2 hours away from an iron or zinc supplement if you're taking that, and take at least 4 hours away from any thyroid medication if you are on that. I also want to note here that calcium supplements have been linked to increased risk of kidney stones. There is also some research that show that it may increase risk of heart disease and also colon polyps, although this is still inconclusive. So what about vitamin D? So some good sources of vitamin D are sunlight. Get at least 10 minutes a day of sunlight. Fatty fish, such as salmon, mackerel, tuna has vitamin D. Fortified dairy products or fortified milk alternatives. Supplements have vitamin D. D3 is the preferred form. So D3 is more effective at raising the levels of vitamin D in the body than the D2 is. And as I said previously, I do recommend supplementation with 1,000 to 2,000 IUs a day for those with celiac disease. So 1,000 IUs daily for those under 12 and 2,000 for those over 12 years of age. And those that are low or deficient, they may need a higher dose or a prescription dose depending on the individual case. Okay, I just wanted to include this label here. I know we always read labels, obviously, because we're always looking for ingredients. However, most of us just look at the ingredient label and don't look at the other stuff. So I just wanted you to pay attention to the nutrition facts label as well. And here are some things to get more of, such as dietary fiber, vitamin D, calcium and iron, and potassium, because those will be listed on the label. And here are some things you want to limit for bone health. High sodium foods, you aim to get less than 2,400 milligrams of sodium per day. Limit alcohol to less than 1 to 2 drinks per day. Drink coffee and tea in moderation to reduce the caffeine intake. And limit or avoid soft drink. The caffeine and the phosphoric acid found in colas may increase bone loss. And also avoid smoking, as smoking increases bone loss and it also reduces the absorption of calcium. And then finally, weight-bearing exercise and resistance training can be beneficial for bone density and also curb bone loss. So some examples of weight-bearing exercises are walking, yoga, dance, hiking, and stair climbing. And examples of resistant training are free weights, resistant bands, and weight machines. So according to physical activity guidelines for Americans, adults need 150 minutes of moderate intensity activity and 2 days of muscle strengthening activity. So 150 minutes translates to about 30 minutes, 5 days a week. And CDC recommends children to get about 60 minutes or more of moderate to vigorous intensity physical activity a day, and do muscle and bone strengthening and exercise at least 3 days per week. But always, consult your doctor before starting a new exercise regimen. as not all exercise is going to be appropriate for everyone. All right, and then in summary, the gluten-free diet is key for optimum absorption of nutrients for bone health. Regular follow-ups with your GI doctor and dietitian are important. Eat a healthy and varied diet focused on whole foods, such as the gluten-free Mediterranean diet. And supplementation may be needed to address deficiencies. All right, now we're ready for questions.
Yeah, thank you so much. A lot of great pearls in there, Katarina. So I'd like to invite all of our panelists, Julio and Deb, to join on camera, and we will start with questions. We've got about 10 minutes and lots of questions to answer. So just to note, a number of questions have come in about sort of personal recommendations. Please note that our speakers can make general comments about what is known about the science and medical practice, but any specific recommendations, you really should be going to your personal doctor or endocrinologist for advice. So with that, one question that came up very early, I think is important to discuss, was on the relationship between bone density and bone strength. And I think maybe Dr. Mitchell, you want to address that?
Yeah, I'm happy to, and then others can chime in. So there's really good empirical data to look at a correlation of bone density as measured by DEXA with fracture risk. So it's a very strong correlation, but it's not the only important thing. So there are a lot of other things that go into that equation. So age is really, really important. So if you take, for example, a woman who's 60 and a woman who's 80 who have exactly the same bone density, that woman who's 80 has a much higher risk of fracture, probably due to changes in the matrix of the bone, and probably also due to increased risk of falls. And then they're important. So Dr. Bai really highlighted the importance of microarchitecture, and we know from some really great work that microarchitecture independent of bone density is also really important for bone strength and resistance to fracture. So while bone strength is quite important, it's one of many factors that go into fracture risk.
Thank you. So the next one, we got a lot of questions about what to do if you're at a somewhat older age, maybe post-menopause, or I guess in men post-andropause, and you've had celiac disease for a while and you have some osteopenia. Is there anything you can do? What is the status of using medications or exercise, or is it really sort of too late for you? And maybe Julio, you want to start, and then Deb and Katarina, feel free to jump in.
Well, some people, some of the audience ask about, I had celiac disease, but I persist having very low bone mineral density. And I think that the main message that you can give to these people is that it's impossible to go above the peak of bone density, or the peak of bone mass that you achieve when the disease started. And that is the reason why many patients still persist years after initiated gluten-free diet, persist with low bone mineral density. But I think that a good message for them is that the prevalence of fractures, despite having a low bone mineral density, is almost similar to a normal people, or people of the same age and the same gender. And probably the situation is those who had malabsorption may increase their size, their structure, and also their fat, and they have more resistance to falls or folding in any case, and they have no fractures because that, even having low bone mineral density.
Thank you. Katarina, any special recommendations for people at an older age that you give?
Yeah, so then, chiming into what Dr. Bai said, managing the gluten-free diet very well, going to follow-ups, making sure you're on track, and taking a multivitamin daily with the extra vitamin D, and also making sure you're getting enough calcium foods a day, getting that 1200 per day, and then also combining this with doing exercise. So at least 30 minutes a day, and then 2 days a week of doing like a bone strengthening exercise resistance training.
Wonderful. Thank you. Maybe back to Dr. Mitchell. There were a number of questions about any concerns regarding the use of oral contraceptives or birth control or hormonal therapies in general for people with celiac disease and who are at a higher risk of bone density issues. What is your advice, or what is known about this?
Yeah, great question. So it's a really active topic of research. So I'd say what we know is the one contraceptive that I tend to recommend against for patients is Depo-Provera. So that is a IM injection of progesterone, and it really dampens the body's ability to produce estrogen. And estrogen is really, really important for bone health. We know that estrogen deficiency will accelerate bone resorption. So we really want adequate estrogen levels. When we think about the standard oral contraceptive pills, so kind of that's a combination of progesterone and estrogen, in general, they may have very minor effects on bone density, but those are probably outweighed by all the beneficial effects in terms of providing contraception, as well as, treating dysmenorrhea or PMS symptoms in women who have those. The one caution there is I would be a little bit worried. There are some OCPs out there on the market that have very, very low levels of estrogen, kind of in the 15 to 20 micrograms of ethinyl estradiol. Those are thought to have less side effects, but probably don't mimic endogenous levels of estrogen quite as well. So for people who are worried about their bone health, I tend to go for more of a middle of the range OCP.
Thank you. There are also a number of questions, maybe to Dr. Bai, about, we've been talking and really focused on celiac disease and bone density issues. Is anything known, or are there any concerns about non-celiac gluten sensitivity and reduced bone mineral density?
Well, in my knowledge, there is no study about bone mineral density and non-celiac gluten sensitivity. In general, it's a very symptomatic disorder, but there is no good evidence about complications in this kind of patient, at least complications that celiac disease patients have.
Great, thank you. And I think we have time maybe for one last question and maybe a couple of closing remarks from all of the speakers. So we had a number of questions, maybe Katarina, you can address, about fussy eaters and enriched grains that are that are a little easier to sell to the family or kids. What do you recommend if people are really having trouble figuring out a way to get palatable, good, bone-focused nutrition in their diet?
Right. So yeah, fussy eating with kids. So with kids, because they generally, they have their safe foods and they're not safe foods they don't love when you're introducing all these new foods. And it usually takes a lot longer for a child to accept a food than we give up. Research shows it takes 12 to 15 times to introduce a food before a child accepts it. And the key is also, when you're introducing a new food, always have a safe food with it. So something that they do like. I mean, obviously it needs to be nutritious, not candy or something like that. But always offer the new food with something. Let's say they like mac and cheese. And you want to introduce broccoli. So introduce it with that safe food, broccoli with a mac and cheese. And do a small serving the first time. And then this is a good way of not really food, because you're not forcing them really to eat it, but it's kind of an exposure. And then you can go in different steps, like that they're picking it up first, smelling it, and the next step is to put their tongue on it, and then the next step is eating the food. So I know with the picky eating, that can be really frustrating. And another thing is to Eating meals together also fosters a lot of that they just kind of naturally will accept foods because they're seeing you eating that food, and that's also an exposure. And I mean, there's also ways where you can hide healthier things in foods as well, like fibers and things like that. When you're baking, you can tuck things in there, like kids that usually don't get enough fiber. So you can put things like ground flaxseed, you can hide in a lot of different things. But for kids, getting enough calcium is usually pretty easy because they usually like those calcium foods. It's usually what you have the most problems with, I think, is the fruits and veggies. And that I just recommend a gradual kind of approach.
Never easy. Great. Well, with that, I think we are at time. Chris, you can come back on, but I want to thank the speakers. This was a really fascinating and educational for everyone. I love the questions. We've done our best to answer ones that have come in online. And as usual, keep watching the Harvard Celiac Center websites and National Celiac Association websites for future talks. So with that, thank you very much for everyone's participation.
Yeah, thank you, Dr. Leffler, and thank you to all of our presenters and attendees for your participation. We hope all in attendance found this webinar educational and helpful. As Dr. Leffler said, please watch for the announcement of topics for the spring 2024 Harvard Medical School National Celiac Association webinar series, which will be held in February and April. You can visit our websites and watch our social media accounts for updates on that. So from all of us here, we look forward to seeing you next time, and we thank you for your continued support.